Welcome to our online weight loss surgery information seminar, offered to you by the Institute for Advanced Bariatric. The Institute for Advanced Bariatric Surgery is a practice of general surgeons. While still performing general surgery like hernia repairs and gallbladder removal, we specialize in laparoscopic weight loss surgery. We have over 15 years of experience performing weight loss surgery. We have performed well over 1,500 laparoscopic weight loss procedures. All weight loss operations are performed laparoscopically, even revisions and repairs of old existing weight loss procedures. IABS performs surgery at the Minimally Invasive Surgery Hospital, or better known as MISH. MISH is Joint Commission accredited, a MBSA QIP accredited comprehensive center, and Medicare and Medicaid certified. MBSA QIP stands for Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. The center has no patient weight limit restrictions or weight loss operation restrictions. A MBSA QIP center caters to the needs and care of bariatrics patients, thus improving outcomes. Things we will talk about today. Why weight loss surgery? Weight loss surgery is a difficult decision for most. Often a new diagnosis of diabetes or being told you have to start insulin to treat your diabetes is a trigger for many patients to seek more aggressive help with weight loss. There are over 30 medical problems blamed on excess weight, and weight loss alone can often improve and resolve many. We will talk about how weight loss surgery works. We believe our job is twofold: give you a good weight loss operation and then teach you how to use it correctly to get the weight loss you want for long-term success. We will definitely talk about what you can expect from a weight loss operation, including how much weight can be lost, how fast the weight can be lost, and how the operation helps to make the necessary eating habit and lifestyle changes to succeed. The three main weight loss operations that we will talk about in detail are the sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. We will finish with the key to success. Weight loss surgery is often referred to as a tool. We will teach you how to use that tool. For weight loss surgery to do for you what it has done for many, we have to teach you about the rules. The last few slides will discuss the rules and give you a very good idea of what the rules entail and what you will need to do and know to succeed. If you have been looking into weight loss surgery, then you are familiar with the term body mass index, or better known as the BMI. BMI is a number generated by a formula that uses weight and height. BMI allows us to measure the severity of obesity. If a BMI is between 18 and 25, a person is considered a normal weight individual. If the BMI is between 25 and 30, we begin to call it overweight. 30 to 35, we call it obesity. Once the BMI crosses 35, we begin to call it severe obesity. A BMI of 40 or more, we call that morbid obesity. Morbid obesity implies medical problems. Once the BMI crosses 40, we begin to see medical problems as a direct consequence of the excess weight. Weight loss surgery is commonly offered once the BMI is 35 or greater. The easiest way to calculate your BMI is probably to go online and Google BMI calculator and punch in your height and weight for you to determine what your BMI is. BMI is also used by all insurance companies as a criterion for weight loss surgery coverage. Most insurance companies start at a BMI of 35, particularly when medical problems are present. Many insurance companies will cover weight loss surgery once your BMI is 40 or more, regardless if you have medical problems or not. Another common insurance company criterion is proof of past dieting. Many require proof of a 3 or even 6-month dieting regimen under medical supervision. It varies broadly from insurance company to insurance policy. Our office will help you determine the criteria your insurance company requires and even help you meet them. So why weight loss surgery? Why you may be watching this seminar today? Well, there are over 30 serious medical problems that are directly caused by excess weight. Unfortunately, there are also very serious medical problems. Medical problems such as diabetes, hypertension, cardiovascular disease, sleep apnea, heartburn, and joint problems. Weight loss alone can reverse many of these depending on how advanced they are at the time of weight loss surgery. What else do we know about excess weight? Well, we know that when the BMI increases, so does the death risk. The risk increases exponentially. The risk increases faster than the BMI. For example, if your BMI is 37, the death risk is about twice that of normal. If it is 39, the death risk increases to 2.5 times from that of normal, and so on. If we know your age and your BMI, we can now predict the weight's impact on your longevity in years. So let's look at the red bars. The red bars represent individuals that are 20 years old. Let's pick the 20-year-old with a BMI of 45. That's on the far right, which is considered morbidly obese, and compare him to a 20-year-old with a BMI of 25 on the far left, which is considered normal weight. The 20-year-old with a 45 BMI will have her lifespan shortened by 11 years when compared to the 20-year-old with a normal BMI. Thus, the younger you are when you start carrying excess weight, the greater the impact on your longevity and health. Here is one of many studies that brought attention to excess weight as being much more than a weight problem. 15 years ago, we did not refer to morbid obesity as a disease. 15 years ago, we did not believe that excess weight could cause 30 medical problems such as diabetes, hypertension, coronary artery disease, and reflux. 15 years ago, we looked at excess weight as a weight problem. Now, we look at it as a real health issue that is treatable. In this specific study, several thousand patients were enrolled. Half were put in the blue group and half were put in the red group. If a female age 50 with hypertension, diabetes, and sleep apnea was put in the red group, another just like her was put into the blue group. The two groups were matched up as much as possible to be able to compare the two groups later. The blue group, in this case, lost weight with weight loss surgery and sustained their weight loss for 5 years. The red group was a comparison group. They did not change anything they did and did not lose weight. We then compared both groups at 5 years. What did we learn? In the blue weight loss group, only 0.68% of those patients died during that 5-year period, while in the red group, the group that did not change anything about their eating habits or lose weight, more than 6% of them died during this 5-year period. So, by simply losing weight and keeping it off for 5 years, the blue group was able to almost normalize their death risk. This was big news at the time. We learned that the metabolic syndrome is treatable and potentially a reversible disease. We also learned that many of the serious medical problems got significantly better or resolved. Such problems as cancer, infections, joint problems, diabetes, and cardiac issues all improved. We learned weight loss alone can be a very effective treatment for many serious medical problems. Excess weight affects the entire body, every organ system, and when weight is lost and kept off, medical problems get better and lifespan can be extended. So what are the options when a person is serious about weight loss? For the purpose of this presentation, we will divide the options into surgical and non-surgical. Weight loss in general is very difficult and often confusing on how to do it right. We know many patients that have been very successful at losing 100, 200, and even 300 pounds on their own. But as we know, 90% regain it back. We believe the reason why failure rates are high is because many do not understand that permanent change is the key to long-term weight loss success. If you stop and go back to the old ways, you will regain that weight because you are doing exactly what you did before. Permanent weight loss requires permanent change. Permanent change is key. We believe weight loss surgery works because it is no longer just about sheer willpower. Patients now have a serious tool to help them change and establish new eating habits for long-term weight loss success. So you are serious about weight loss surgery. What are your options? The three most common weight loss operations are the sleeve, bypass, and band. Sleeve at present is the most commonly performed weight loss operation in the United States. An evolving field in weight loss surgery is revision surgery. Revisional surgery is a repair or alteration of existing weight loss operations that can also be done laparoscopically. Before we talk about each operation, we first want to discuss how they work. How weight loss surgery works is a question that is still being researched, but there are a few things we know. Restriction and malabsorption appear to be the two main mechanisms, but stomach mass reduction, the neuroendocrine loop, and duodenal lack of exposure to food is also a big player in how weight loss surgery works, particularly during the first year. Let's start with restriction. Restriction is considered by most as the main mechanism. Each weight loss operation has their stomach reduced in size in one way or another. If we are talking about the band, the stomach is reduced to a golf ball in size. If we are talking about the bypass, the nose stomach is about the size of a thumb. Many would believe reducing the size of the stomach alone should be enough to lose weight. There is one more step that we have to do for the small stomach to work the way we need it to. The small stomach must also have a small pouch outlet. In the case of the band, the outlet needs to be about the size of a pencil eraser for it to work right. Once these two things are in place, the operation now restricts how much food a person can eat at a time and how long that food will stay in the pouch and thus keep the person full. The smaller or narrower the outlet, the longer it can trap food and keep you full. Thus, for restriction to work, we need a small stomach with a small drain. The smaller and narrower the stomach, the less can be eaten at a meal. And the smaller the drain, the longer we can keep the pouch full by making it difficult for it to empty. All weight loss operations use restriction. Malabsorption. Malabsorption used by the bypass and the duodenal switch. Malabsorption is the alteration of the GI tract in such a manner that part of it does not see, digest, or absorb food anymore. In other words, we rearrange the plumbing in such a manner that some of the piping does not see water or food in this case. The more intestine we bypass, the less intestine is available for food digestion and thus absorption. So even though you are eating small amounts of food, you may not be able to absorb all of the food you are eating. Portion control is ultimately what weight loss surgery is all about. The key to weight loss in bariatric surgery is portion control. If we can control portion and prolong fullness, then we can control calorie intake. The other mechanisms are often considered side effects or negative feedback mechanisms and are very important bonuses that enhance what restriction does to further aid in eating behavior and lifestyle modification, promoting compliance, motivation, and further weight loss. Surgical options. We will now go in detail about each of these weight loss operations, the sleeve, the band, and the bypass. For each operation, we will show you how the operation is done, explain what you can expect from each, and what are the unique negative feedback mechanisms that further promote eating habit and lifestyle changes. First, let's start with a brief introduction about each. The sleeve gastrectomy. The sleeve gastrectomy is now the most commonly performed weight loss operation in the United States. It was finally approved as an independent weight loss operation in 2007. It has become popular because it is a great compromise between risk and benefit. It works a lot like the bypass, but with lower risk and complications. Many people find it attractive because it is a simple operation. 80% of the stomach is removed without altering the lower GI tract or digestive process. All cutting operations have an almost immediate impact on diabetes. The cutting operations are the sleeve and bypass that we're talking about today. If the diabetes is of a more recent onset, still being treated with oral meds, or just recently the patient was started on insulin, there is a significant chance at a cure. We use the word cure, but we really do not cure diabetes. We likely put it into remission or get it under control. The more invasive the operation, the better the cure or control rate over the diabetes is. Of the 3 weight loss operations, the sleeve is the only weight loss operation that is not reversible. Sleeve is also the newest weight loss operation of the 3, and solid, long-term 15-year-old follow-up data is just beginning to accumulate. The Roux-en-Y gastric bypass. The bypass is now the second most common weight loss operation performed in the United States. It remains the gold standard of weight loss surgery to which all other operations are compared to. It has been around the longest and has the longest track record. The bypass impact on diabetes is stronger than the sleeves by about 10-15%. The impact is almost immediate and continues to improve with weight loss. The bypass is not offered to everyone for the asking. Patient medical health has to be reasonable, or in other words, operative risk has to be acceptable. The bypass is one of the more riskier operations performed for weight loss. It is a safe operation when chosen on appropriate patients. Risk of dying from a bypass operation is lower than the risk is from dying from a gallbladder or hip replacement operation. The Lap-Band. The Lap-Band is now the 3rd most commonly offered weight loss operation in the U.S. It was approved for use in the U.S. by the FDA in 2001. It currently is the least invasive and lowest risk weight loss operation available. There is no stapling or cutting of tissues and no intestinal rerouting. Its adjustability put it on the map. It no longer matters how thick the stomach wall is or how much padding is present on the stomach wall. The band can be adjusted just right for each patient. Of all the weight loss operations, it has the lower weight loss totals and success rates. The weight loss is slower, and it has a slower impact on medical problems associated with morbid obesity. Of all the weight loss operations, we believe it has a harder ventricular learning curve. The band does not work unless it is properly adjusted. It is very important to get it adjusted right. Once adjusted, that's when the band starts working and the real weight loss starts. Now we will go into detail about each operation. Let's start with the Roux-en-Y gastric bypass. Now we will show you how the bypass operation is done.
The Roux-en-Y gastric bypass involves a modification of the stomach so that only a small amount of food can be eaten at one time. A small pouch about the size of a person's thumb is created at the top of the stomach. Next, the small intestine is divided about 2 feet from the stomach. The lower portion of the small intestine is then brought up and attached to the small stomach pouch. The upper portion of the small intestine, still connected to the now non-functional stomach, is reconnected to the intestinal tract 30 to 60 inches from the stomach pouch. As gastric bypass implies, following the surgical procedure, food is routed past much of the stomach and the first part of the small intestine. Patients lose weight because this small stomach pouch restricts the amount of food that can be eaten comfortably, and patients feel full after eating very little food. In addition, a process called malabsorption also helps patients lose weight because a portion of the natural digestive tract is circumvented. As a result of this circumvention, the amount of calories as well as nutrients absorbed by the body is reduced.
So, what can you expect from the bypass operation regarding weight loss? The most commonly quoted weight loss number in the literature for the bypass is about 70% of excess weight over 1 to 1.5 year period. So what does that mean? Probably the best way to illustrate is by example. Let's have a patient that weighs 300 pounds. To keep our math simple, we will give this patient an ideal body weight of 100 pounds. So if we do the math and subtract 100 from 300, that means this individual has 200 pounds of excess weight. 70% of 200 is 140. If this individual chooses the bypass, this individual will lose 140 pounds, half of which 70 pounds or so in the first 6 months, and the remaining 70 pounds over the next 6 to 12 months. Success rate is high, about 80%. 80% of patients are able to keep off at least 50% of excess weight at 5 years. At the 5th year mark, many patients we have not seen for a few years start returning concern because they have regained 25 or 35 pounds and they want to understand why. The most common cause is compliance. They are not following the rules. Often, when we ask what are the 3 rules, we are lucky if they recall one. If they do not know the rules, that means they do not follow the rules, and this will affect weight loss. After we go over the band and the sleeve, next we will fully explain the rules and how the rules work. Many people choose the cutting operations, which includes the bypass and sleeve, because of what we like to call the honeymoon period. All cutting operations have it. The more invasive the operation, the more dramatic the benefits or side effects during the honeymoon period are. Females will also experience them more intensely than the males, but the males have a tendency to lose weight faster than the females. The honeymoon period lasts during the first 6 to 12 months after surgery. During this period, patients are not hungry. Patients often have to remind themselves to eat. Sugar tastes a lot sweeter. 1 teaspoon of sugar in your coffee will now taste like 3 teaspoons of sugar. Many recipes like Crystal Light will have to be diluted with extra water for it to taste right. The olfactory sense is significantly heightened. Food tastes and smells different. Often your favorites are no longer your favorite foods anymore. Your cravings and urges change. The restriction of your operation is at its peak during this time. Portion restriction is very strict. In the first 2 to 3 months, up to 2 ounces is the average portion size tolerated. At about 3 to 4 months, 2 to 3 ounces. Around the 6 to 9 month, the portion is a comfortable 3 to 4 ounces. Because of this strong restriction in the beginning, the weight loss is fast. The calorie intake is about 600 to 800, then 1,000, 1,200, and about 1,500 calories at the 6 to 9 month mark. Dumping syndrome is also another side effect of the cutting operations. Dumping is something like what a diabetic experiences when he took his insulin but forgot to eat. The blood sugar level drops. As a consequence, they get dizzy, lightheaded, diaphoretic, experience heart palpitations, break out in a cold sweat, and often feel like they will pass out. In a weight loss surgery patient, something very similar occurs when too much sugar and or too much fat is eaten. The patient may be able to handle 1 or 2 fried chicken drumsticks, but not 3. If they eat more fat or sugar than they can handle, they will dump. Dumping is unpleasant or a negative feedback mechanism. It is helping our patients change their eating habits. Ice cream and fatty foods stop being appealing to many because of dumping. The next operation we will go into detail about is the lap band. This is what the band looks like. The round, hollow, band-like circle is the band. The solid cylindrical device at the other end of the tubing is the port. The tubing connects the port to the band. To the right is how the band looks like sitting on the stomach. The small stomach above the band is what we call the pouch, and it is about the size of a golf ball. Once the band is adjusted correctly, the passage between the pouch and remaining stomach is about the size of a pencil eraser. The band is adjusted by injecting water into the port. The water then travels along the tubing, filling the balloon that is lining the inside of the band. The more water is injected, the bigger the balloon gets. The tighter the band, the smaller the passage between the pouch and the stomach, and the harder it is for the food to empty out of the pouch. Here we have a video showing you how the lap band operation is performed. We make 5 small incisions through which we introduce the trocars. We use the trocars to put our liver retractor, camera, and various instruments in to perform the operation. First, we bring the stomach back into the abdomen from the chest when needed. Then we create a tract behind the stomach through which we introduce the band. We then clamp the band into place. We pull the tubing out and connect it to the port. Port is placed under the skin. Here we show how an adjustment is done. A needle is used to access the port. Water is then flushed through the port into the tubing, inflating the balloon lining the inside of the band. Here is what the balloon lining on the inside of the band looks like inflated. The more the balloon is inflated, the more it squeezes down on the stomach wall, making the passageway tighter and tighter, and more difficult for food to empty out from the pouch, thus trapping food in the pouch for longer periods of time. In the picture to the right, a fill or adjustment is performed by using a Huber-type needle that is inserted through the skin and into the port. It feels something like a flu shot. Water can be injected and withdrawn as needed to get the band adjusted right. We perform fills under X-ray, which allows us to adjust faster because we can see how the fill is affecting the flow through the band. Once the flow gets slow, we stop adjusting, while avoiding making it too tight or loose. We also monitor patients long-term under X-ray to ensure that the band remains adjusted right and to keep patients out of trouble. So, what can you expect from the lap band operation? The most commonly quoted weight loss number in the literature for the lap band is about 60% of excess weight over a 2-year period. So what does that mean? Let's use the same example. A patient that weighs 300 pounds and has an ideal body weight of 100. So we do the math, the individual has 200 pounds of excess weight. If this individual chooses the lap band, they will likely lose about 120 pounds, which is 60% of 200. 80 pounds of which they will lose in the first year, and the remaining 40 pounds over the next year. The lap band is attractive to many people because of its low risk profile. With the band, there is no permanent change to the anatomy, no changes to digestion and GI tract, and it is easiest to reverse. Its adjustability allows us to adjust it just right for every patient. It is also often used as a staging operation. Many patients are too high risk for any of the cutting operations, and often we stage with the band to help the patient lose enough weight to place them in a better health category to take on the riskier cutting weight loss operations if there is still a need after the band. The last operation is the sleeve gastrectomy. The first step in the sleeve operation is pulling the stomach out of the chest and putting it back into the abdomen and repairing the hiatal hernia. A great majority of our patients have a hiatal hernia and heartburn. Weight loss surgery is kind of 2 operations in one. We fix your heartburn and we give you a weight loss operation. By doing this, we know exactly where the stomach starts. If we do not repair the hernia, a large amount of stomach can be left behind in the chest and increase the size of your pouch. Next, we mobilize the outer greater curve of the stomach and we put a bougie all the way into the stomach. A bougie is a long, blonde, solid tube as shown in the second picture in blue. Anesthesia advances it into the stomach till it reaches the small bowel. It is used as a sizer. Every stomach has a different shape, thickness, padding, and size. A bougie ensures and allows us to cut the stomach just right every time without making it too tight or too loose. The perfect sleeve is a narrow tube from the top of the stomach to the antrum. If we were to cut across the sleeve, the diameter of the sleeve is about the size of a nickel. Ultimately, about 80% of the stretchy part of the stomach is removed, leaving behind the rigid, not so stretchable part of the stomach in the shape of a tube. So what can you expect from the sleeve gastrectomy operation? The most commonly quoted weight loss number in the literature for the sleeve is about 60 to 70% of excess weight over a 1 to 1.5 year period. In our office, we quote 70%. Again, the best way to illustrate what that means is probably by example. So again, the same patient, he weighs 300 pounds with an ideal body weight of 100. When we do the math, this individual has 200 pounds of excess weight. If this individual chooses the sleeve, we can predict that this patient will lose 140 pounds, which is 70% of 200. Half of which will be lost in the first 6 months, and the remaining 70 pounds over the next 6 to 12 months. The sleeve works a lot like the bypass operation, but with less short-term and long-term risk. It became an alternative operation to the bypass for higher risk patients, and as we have worked more and more with it, it has become the operation of choice for most patients and surgeons. As we mentioned earlier when we talked about the bypass operation, the sleeve is a cutting operation. It also has the honeymoon period. As a reminder, the honeymoon period lasts for the first 6 to 12 months after surgery. During this period, patients are not hungry. Sugar tastes a lot sweeter. 1 teaspoon of sugar in your coffee will now taste like 3 teaspoons of sugar. The olfactory sense is significantly heightened. Food tastes and smells different. Often your favorites are no longer your favorite food, and your cravings and urges change. The restriction part of the operation is at its peak during this time. Portion restriction is very strict. In the first 2 to 3 months, 2 ounces or less is the average portion size. At about 3 to 4 months, 2 to 3 ounces. And around the sixth to ninth month, portions become a comfortable 3 to 4 ounces. Because of this strict restriction, the weight loss is faster. The calorie intake is about 600 to 800, then 1,000, 1,200, and about 1,400 calories at the 9-month mark if rules are followed. A dumping leg syndrome is also a side effect of the sleeve gastrectomy. Dumping is a negative feedback mechanism. It helps our patients change their eating habits, particularly when it comes to sugar and fat. Ice cream and fatty foods stop being appealing to many because of dumping. As we alluded to earlier, weight loss surgery is not the solution to weight loss. It is a tool to help lose weight. Our job is twofold: give you a great weight loss operation and then teach you how to use it. The weight loss operation is a tool. The more you understand how it works, the better you can make it work for you and the more weight you can lose. In order to experience what weight loss surgery can do, not just short term, but more importantly, long term, you will have to follow the rules. If you are following the rules, the operation will restrict how much food you can eat at one time, no matter how delicious it is or how much you would like to eat, and keep you full on that small amount of food for about 4 hours. The beauty of weight loss surgery is that for the first time, you will feel full and satisfied from what you eat. Your hunger will be controlled. This can be a profound experience for many, being released from a prison of hunger, if you follow the rules. The rules. There are 3 rules. The rules have nothing to do with nutrition. The rules are not about what foods are good or not good for your health. Cheating does not mean you are eating fatty or high-carb foods. Cheating in weight loss surgery means you are breaking one or more of the 3 rules. The more rules are broken, the more you are turning your operation off. Rules turn it on, breaking the rules turns it off. The first rule: minimize liquids with calories. This is a rule because it does not matter how small we make your pouch and drain. Liquids drain out of the pouch while you are still drinking. We cannot keep you full on liquids. Thus, there is no satiety or satisfaction from a liquid. But every calorie of that liquid will pass through and be absorbed. Weight loss surgery cannot keep any pouch full with liquids. This is the easiest way to cheat any weight loss operation. We cannot fill or keep you full on liquids. A liquid with calories is anything that pours, goes glub glub, or you eat with a spoon or from a cup or bowl. If you want to experience the opposite or experience what weight loss surgery is capable of, it is all about the solid, dry, dense, and doughy foods. Rule number 3. Rule number 3 states, eat solid, dry, dense, doughy foods as much as possible. The denser, drier, doughier, and more solid the food is, the better and faster the pouch fills up and stays full. The more solid, dry, dense, and doughy foods you eat, the less you can eat and the longer you stay full, and the better your hunger and cravings will be controlled. And the faster you will lose weight and keep it off. Examples of solid, dry, dense, doughy foods would be a sandwich, a hamburger, a steak dinner, or a slice of pizza. What goes down a sink drain easier, a bowl of soup or a hamburger, a bowl of chili or a slice of pizza? And this leads us to why we need the second rule. Rule number 2 states, do not eat and drink at the same time. What is going to help that hamburger and slice of pizza go down the sink drain? What do we all do when we want to help a hamburger go down a sink drain? We run the faucet. We add water. Water helps. Water speeds up the emptying process, and that is not what we want. We want to trap food. and keep you full for as long as possible. Liquids while eating do not work with weight loss surgery. So if you go to a restaurant and you order diet iced tea, you can drink as much of it as you want as long as you stop about 5 minutes before your meal arrives. We want the sink, your pouch, to be dry when you start eating. Once you start eating, no more drinking during the meal. And do not drink after the meal because you will flush everything you ate down the drain and be hungry earlier than you were meant to be. Mother Nature does not need help from us to liquefy the food in your pouch. If Mother Nature is allowed to do it on its own, the pouch will stay full longer, controlling your appetite, cravings, and hunger. The rules are about the mechanics of your operation, or better, how a sink works. The operation follows the rules of gravity. The rules are instructions on how to turn your tool on. If you follow the rules, your operation is on. If you break the rules, it is off. When it is off, you are on your own. You now have to control portion size because the operation cannot. Solid, dry, dense, doughy foods. Here are examples of foods we would consider solid, dry, dense, doughy. We would approve of any of the food choices that you see in these pictures. What don't we see in these pictures? We do not see the food swimming in a pool of liquid, sauce, or gravy. You do not see sauce or gravy dripping off the food. You do not see things squeezing out the side of the hamburger or sandwich. Food is a little drier, a little simpler, but it does not mean it can't taste good and be flavorful. More examples of solid, dry, dense, and doughy foods. Your food can be delicious as long as most of it is solid, dry, dense, and doughy to engage the operation. Let us use pancakes for an example. We approve of pancakes. If you want to put 2 sticks of butter in your pancake batter or use heavy cream instead of 1% milk and add maple syrup, we would be okay with that. It is not necessarily what we recommend because of the amount of fat, but it will work with the rules and we can give you portion control as long as when you pour that batter out on that griddle, your pancake comes out nice and fluffy, doughy, and thick. The thicker and breadier the pancake, the better the portion control will be. But, there's always a but. But we won't let you put a pat of butter or a dollop of cream or a tablespoon of maple syrup on top of your pancake. Why, you ask? What happens when you pour maple syrup on a pancake? The pancake turns into a mushy, pulpy mess. Once the food is mushy, saucy, or runny, pulpy, the operation does not work as well. It's like eating and drinking at the same time. Now you would be able to eat the whole pancake or more depending on how soft, mushy, and runny it became. There are no ingredients that are really off the menu as long as the end product is solid, dry, dense, and doughy. Soft, runny, saucy, mushy. Now compare these slides to the 2 previous slides that we just looked at. Here, with these food choices, we are not doing as well. It is harder for your tool to trap these foods in your pouch, thus you are able to eat more and will not feel full for as long. Foods like casseroles, pot pies, chili, stews, foods that come with a lot of sauce or gravy, chicken salad, tuna fish salad, seafood salad, potato salad, egg salad, pasta salad, cottage cheese, yogurt, soup, pudding, oatmeal, or cereal with milk are not solid, dry, dense, and doughy foods. Weight loss surgery is not able to portion control these types of foods. It does not mean you can't eat these foods, but when you do, you are on your own. Your portions will increase in size. By how much will depend on how soft, runny, saucy, mushy the food is. For example, the Chilean lasagna, we would grade with a D or an F. The pie in the picture would probably be a D. The casserole, a C. The peanut butter and jelly sandwich, maybe a C+. So there's degrees of cheating. The more rules you break, the more cheating you're doing, the higher your portion goes, and the faster you will empty, and the sooner you will be hungry. More examples of what we would consider soft, runny, saucy, and mushy foods. A very simplified version of the rules could be interpreted as, if you can eat it without needing to chew it, to be able to swallow it, most likely you are cheating. Foods that require a fork and a knife to eat do a lot better with weight loss surgery. Liquids. Good versus bad liquids. This is pretty easy. If it tastes good and you are praising how good it was, you are probably drinking a bad liquid. Bad liquid means it has calories. And it does not matter if the calories are healthy, like milk, soup, yogurt, or a protein shake. If it is a liquid with calories and it pours, goes glug glug, or if you have to eat it with a spoon or from a cup or bowl, you are most likely cheating. The good liquids are the ones with aftertaste. Those without calories are those sweetened with sweeteners. Those you can have in unlimited amounts because there are no calories in these liquids, and it does not matter how much you drink as long as it is not around mealtime. Summary points. We are almost done. This slide is meant to summarize the main important points that we would like you to take away from this seminar. First point, weight loss surgery offers a tool, not a cure. Weight loss surgery, especially in the first year, will have very strict control over most patients and will force eating habits and lifestyle changes whether they are wanted or not. But if by the end of the honeymoon period the patient has not incorporated the rules into their daily way of life, it will change the weight loss. The operation helps to a very large degree, but it cannot do it all on its own. The rules are necessary to ensure the operation continues to work by keeping the eating habits and lifestyle changes permanent. Second point, weight loss will remain a daily struggle, but easier. This is probably the best statement we can make. Weight loss is not easy even with weight loss surgery. Weight loss will remain a struggle. Weight loss surgery just makes it a lot easier to accomplish. Third point, weight loss surgery will work a lot better when the 3 rules are followed. Weight loss surgery is only a tool. Rules are what makes it work. To keep the weight off, rules are necessary. The more often the rules are followed, the better the weight loss operation works and the better the weight loss will be. Next steps. If you already know you are ready for weight loss surgery, the next best step is probably to contact our office to meet the surgeon. The phone number is 913-322-7401. The surgeon will see you for all your visits before and after surgery. We also recommend you can call first and have our staff verify whether or not your insurance company covers weight loss surgery or not. You may also contact your insurance company on your own and learn about the criteria to qualify for weight loss surgery, or you can read your insurance policy manual and look up weight loss surgery benefits or bariatric surgery benefits to learn more. If you are still undecided, keep educating yourself about weight loss surgery. You can attend a live seminar presentation with more detailed content, or meet and talk with our weight loss surgery patients that already had surgery. Weight loss surgery patients are very happy to share the good, the bad, and the ugly about their weight loss surgery experience. They are a very important source of information for anyone considering weight loss surgery. So if you do not know many patients with weight loss surgery, please attend a meet and greet, a nutrition class, a behavior modification class, a rules class, and or our patient support group to meet these patients and learn more about weight loss surgery. Also, please explore our website. There is a lot of information there. Under the Patient Corner tab, you can find the diet guides. They will tell you everything you need to know about your diet after surgery. The Surgery Preparatory Guide will tell you almost everything else you need to know when preparing for weight loss surgery. The very last thing we have for you are patient before and after pictures. Please do not forget, if you need insurance company credit for weight loss surgery patient education, please complete the quiz and submit it at the end. We hope you have found this presentation helpful as well as educational. Thank you, and we hope to hear from you soon.